The subject of today's seminar is traditional medicine and Ayurveda. The Global Health History Seminar series was established in late 2004 and is jointly hosted by the World Health Organization and the WHO Collaborating Center for Global Health Histories at the University of York. Seminars take place almost once every month and are broadcast via the internet. This year we'll have altogether 10 seminars, of which 8 will be organized at WHO headquarters in Geneva, and 2 will be at WHO Regional Office for Europe in Copenhagen. I'm honored to introduce my co-chair, Professor Banerjee, Director of WHO Collaborating Center at the University of York, and our 2 speakers today, Professor Madhulika Banerjee from University of Delhi, India, and Dr. Zhang, Coordinator of Traditional and Complementary Medicine of the World Health Organization. Each of the 2 presentations will last for about 25 minutes, followed by the Q&A session, respectively, for the speakers, which will be chaired by Professor Banerjee. Kindly remind everyone to speak into a microphone and give your name, since the seminar is broadcast via the internet. So today, as an exceptional case, WHO speaker will make the presentation first because Dr. Zhang has to go to the airport directly on duty travel. Apologize for that. The first speaker is Dr. Zhang. Dr. Zhang joined WHO in 2009 and became coordinator of Traditional and Complementary Medicine program in the Department of Service Delivery and Safety in 2010. He studied in both conventional medicine and traditional medicine, and he used to be a doctor, researcher, and a government official responsible for traditional medicine in China. Before working at WHO, Dr. Zhang led the work of integration of traditional medicine services into national health care system in the Department of Healthcare Services, and headed the Department of International Cooperation of State Administration of Traditional Chinese Medicine. He was also the Vice President of China Academy of Chinese Medical Sciences, the National Research Institution for Traditional Chinese Medicine, leading the supervision on services, management, and clinical research in the 5 hospitals affiliated to the Academy. Dr. Zhang, please.
Thank you, Jing, for your introduction, and also thanks, Sanjoy, for inviting me to give a briefing today, focusing on the introduction of WHO traditional medicine strategy for the next 10 years. My presentation will be into 3 parts. Firstly, of course, some background and progress in the last decade in the area of traditional and complementary medicine. Also, some major challenges we are facing in this area. Also, the strategy and the implementation. As you may know, that traditional medicine globally is diversified, and also almost every country has some kind of traditional medicine. Majority, we cannot say already. For example, last year I went to Sierra region to attend a ministers' roundtable meeting, and all the ministers in that region saying, in my country, it's real traditional medicine, of course. But in terms of globally popular use, here select several we call either system or forms, or the formalities are some different word. For example, Ayurveda medicine, and traditional Chinese medicine. Usually in this community they call system, because in Ayurveda or Chinese medicine, not only cover the manual therapy, for example, or medication. They include medication, usually we are saying formulas, even not only single herb prescriptions, and also non-medications, manual therapy, acupuncture, or other exercises, for example, yoga in India, the traditional medicine, qigong in the Chinese medicine, a kind of exercise which benefits to people's health. So we call this a comprehensive form of traditional called system. Others like chiropractic, homeopathy, osteopathy, that seems focusing on either manual or some simple the medication part. It seems not so comprehensive compared to India Ayurveda medicine or Chinese medicine. Some background, because of the not only diversity but also the we call utilization patterns, some kind of different, because we have no so far some very well developed some classification, but is the real some in terms of utilization, there are different patterns. For example, in some countries or regions, traditional medicine is one of the primary sources of healthcare. For instance, in African region, we have ratio here 1 to 500 the healers, traditional health practitioners. But in terms of doctors, it's too less to provide the healthcare services to the people. So this is one category of that. So in that region or country, native healers therefore remain the health providers for millions of people. Dr. Margaret already indicated. Perhaps the traditional health practitioner is the only healthcare providers for millions of people in some regions. Secondly, for example, in other countries, although like Korea, Republic of Korea or Singapore, or even in Japan, 86% of the medical doctors, the daily practice, they prescribe not only drugs, but also chemical medicines, traditional medicine. Like Singapore, Republic of Korea, very well developed health system, but they still use this high percentage of traditional medicine. That's because, of course, culturally, historical influence, but also effective. Otherwise, they will not continue to use. The last category of that we are saying that traditional complementary as a complementary, or some countries call alternative, the similar things, therapy. Is complementary to the conventional medicine. There are countries like European countries or North American countries still now is popular use. Second slide shows some examples, give some figures, give you a sense. For example, based on the research and the data, in European region only, about 100 million now European people use traditional complementary medicine, and of course 1/5 of this figure regular use complementary traditional medicine. Also the same figure, they prefer the healthcare or the GPs, general practitioners who have complementary alternative medicine knowledge and practices. Of course, other regions like Asia or Africa, that's more people use. In India, also another example, provided the data by the government, Ayush, the agency. Currently, there are 785,000 registered Ayurveda, Yoga, naturopathy, these different categories of traditional medicine in India, popular use, so many. And still also on the village-based or primary healthcare context, about 1 million. That's healthcare workers. That's different level. The first the figure is nationally unified education qualification and the test examination for the license. The second level is some local authority determining, or the self-regulation. Anyway, so you can see from the provider, the practitioner side, you can see the size of it. In China, there is a national survey in 2010 showing that in 2009 only there is 907 million people visit traditional Chinese medicine services. There's a national survey conducted by the government. About 18% of all the medical visits in the country, of course not including rural areas, but majority of the institutions, particularly the hospital, all the hospitals surveyed, including comprehensive Western medicine hospitals, and so 13.6 million inpatients that year. That's comprised 16% of all the inpatient hospital survey. That's give you a figure how this showing that when the people are coming to visit traditional medicine services, only an example. For example, the multiple sclerosis based on the research data. In several we call developed countries, you can see 41% in Spain, 70% in Canada, 82% in Australia. The people who are multiple sclerosis visit traditional complementary medicine services. And in China also is a national monitoring center. They monitored almost 20 years so far to the selected sampling 100 hospitals. So you see for inpatients, here the number is not, the disease is not for outpatients. That's so many diseases visit traditional medicine. Here only for inpatients. And based on their data, cumulative data, the top 5 diseases, patients for traditional medicine: cerebrovascular accident, intervertebral disc replacement, hemorrhoids, ischemic heart disease, and essential hypertension. Top 5. That's data accumulated according to the monitoring center. So you have just an idea about what kind of disease usually. But of course, in Korea, in many countries also there is data, the different diseases, top diseases, is medicine. There is an example. There you can see the hospital. Dr. Margaret Chen, DG WHO, last year there is a special feature in Science magazine, and DG provided a foreword. In that foreword, there is one sentence saying that nearly a quarter of all modern medicines derived from traditional natural products. And many of the natural products actually is used in traditional medicine context first, and then developed the modern medicine. So traditional medicine is a resource not only for primary health care, but also for innovation and discovery. So this slide we're showing based on WHO global survey, we can show that in WHO member states, the policy side, the government side, what action they are taking and what's the situation reflect traditional medicine on policy side and traditional medicine. You can see we compare to 10 years ago, 1999 and to 2012. You can see the number of member states with traditional medicine policy. They developed a national policy on traditional medicine from 25 now to 69. Number of member states regulating herbal medicines from 65 10 years ago is 120. And the number of member states with national level research institutes for traditional medicine, you can see also from 19 and now 73. This is particularly important, we think, because it's related to rational use of traditional medicine. If the country is a high level research institute for traditional medicine. This slide showing that based on the latest the survey from 129 countries, you can see the regulation on practitioners, because later I also touched that in the past we more focusing on WHO side, focusing on herbal medicines in the area of traditional medicine. But now we are more also pay more attention to practitioner practice. So the survey including this question. So you can see not as many as countries regulating practitioners as traditional medicine. Now about 53%. Or the 56 countries, less than 50% of member states regulating practitioners. But you can see for herbal medicine already 120, right? Yeah, so, and they're showing countries also from the global survey, 129 countries. The education, not all the countries who are now conducting education, but here is at the university level and beyond. So you can see about 30% countries saying that in that country, right, it's a university level or anyway, master or PhD or postgraduate university level training, education or traditional medicine, less than the regulation for practitioner. Still, some countries. Here also surveyed surveyed about the challenges. So you can see. The number one challenge is lack of research data. Of course, later we also try to identify what's the reason for lack of research data. But here, from the reporting feedback from countries, are saying lack of financial support for research. We think that this is one of the major reasons why not so many particularly high quality research data come out. One of the reasons is not so many foundation or government so far provide financial support to the research. This is one of the reasons, of course, others. And also you see the challenges like mechanism to control, like the advertise claims, still herbal medicines and providers. And of course, some practices. So in general, we now summarized the response from the member states. So we see that the major challenges in general, the progress in the past 10 years relating to regulation of herbal medicines moving faster, while regulation on traditional practitioners is advanced at a slower rate. So from figure, you can see already 120 member states regulate herbal medicines. And also in some countries, particularly the policymakers, the first, the concept of think of traditional medicine, oh, that's herbs, herbal medicine. So that should be regulated. Also, if that regulated everything, it's okay. So that's also, but actually it's not correct, because now it's the question come out. If practitioners practice not very well regulated, only regulate herbal medicine or products, the services cannot be guaranteed quality safety, right? Some prescribers is not qualified. Only products is even the qualified, but the service is not guaranteed quality. So this is the new challenge for the new. So this is the summary. So also we find that member states lack of knowledge in formulating the national policy, either developed or not developed. Anyway, the lack of knowledge for supporting the development of the policy and management. So the lack of regulation on practices, and also lack of the integration appropriately into the health system. Of course, when we are talking about new strategy, we just to see in the past what kind of strategies the traditional medicine area. In 2002, WHO launched the first one, but that's 2002 to 2005. And after that, later, traditional medicine not independent strategy, but included in WHO medicines strategy, 2004 to 7 and 7 to 13. So you can see in the past, actually, even from WHO side, we more focusing on the product side as part of the drug strategy for traditional medicine. So together with member states, that's why also the progress made herbal medicines quality safety regulation is faster. And also 2008, WHO Global Strategy on Public Health Innovation, and also including traditional medicine as a component, and also the action plan. So in 2009, the WHO resolution, representing the voice from member states, request WHO to update WHO the first strategy as an independent one, based on countries' progress, current new challenges. And so you can see, so earlier slides, that member states, the needs and the challenges already changed. So we need to update the strategy. So the new strategy developed this last several years and launched in 2013 by the Director General. This for the next 10 years strategy, 3 objectives, 6 directions. 3 objectives. First one is to build on knowledge base, because we identify countries' lack of knowledge base for management and policy development. So we had the first objective. 2 directions. One is, of course, we're talking about knowledge base. First concept is encourage member states to understand really the situation and recognize the real potential. So build the national country profile. What's the reality? Who are the users? Who are the providers? Why they visit traditional medicine service? What kind of education or background for providers? So the country profile. How many forms of traditional in your country? For example, Turkey. Recent days they are now developing the policy. So after national survey, the experts select 14 forms of traditional medicine now used in Turkey. So they need to regulate or develop appropriate policy coping with the 14 forms of traditional medicine. So if you're not building country profile, just to develop a policy very general or some that's not knowledge based, so this policy or regulation is not deeply founded or makes sense. Second direction under this knowledge base is encouraging the research in the area of medicine to build the evidence base on the knowledge base, and also sustainable the resources including intellectual resources and natural resources. In some countries, the major challenge now is how to conserve or protect the natural process, the resources of medicinal plants. It's also challenging, right? And cannot make sustainable development if not well prepared. Second objective is, of course, strengthen quality assurance, proper use, effectiveness by appropriate regulation. Regulation not only products but also practice and practitioners. Third one is promote universal health coverage by appropriate integration, traditional medicine, complementary service into the healthcare service system. Here is one is capitalize potential contribution to improve health service and health outcome. And also, we emphasize importance of self-care using traditional medicine. So here is the education. So not only the health workers, but also the consumers is very important to ensure that the quality and safety of self-care, because many people use herbal medicines or other interventions as self-care. Of course, WHO strategy developed also several the indicators for monitoring, actually focusing on the directions, policy side, funding for research, and regulation products, practitioners, and how to integrate, and also self-care education side. So, as I said, actually, this last year, in 2014, EB, the process, the secretary report, and also recommended draft resolution and WHO resolution in May last year adopted. And also will be a midterm review for the next 10 years and make adjustment also 10 years later. 2014 will be 2023 will be a final review of the strategy. For the WHA resolution, of course, for urge member states, firstly to adopt or adapt to the strategy to your country context and to implement appropriately as a basis. And also the develop and implement working plans to integrate traditional medicine, complement into the health service system in that country as appropriate for each country. And also will report to WHO for the progress. This resolution also requires DG to facilitate the member states implementation, supporting the knowledge-based policy and the standards, regulation, and also provide policy guidance to the services how to integrate, of course, and also technical can ensure the safety, quality, and the effectiveness of the services. So when we are talking about the implementation of the traditional medicine strategy, of course, it should supporting or promoting the WHO universal health coverage, that's umbrella. So the definition are here, all people are able to use needing health services, of course, of sufficient quality to be effective, and not exposed to use financial hardship. For the designing or coordinating improving services at the point of care or universal health coverage, you can see people, of course, as the center, and also the safety quality side, and also emphasizing improvement, integrating vertically from the prevention to promotion to treatment and to rehabilitation or to palliative care, of course. And health promotion and prevention, primary health care, quality improvement, and managing hospital agenda long term. So all these part, I think, traditional complementary medicine is also a component in, particularly not only the vertically integration, but also emphasizing horizontally. At the same time, different the interventions serving to people. And also need to be not segmented, right? So traditional medicine as an intervention also should be integrated and to verify it and to see how to appropriate and integrate. For the implementation, currently WHO, of course, also conducting many activities. Here is only highlight several examples. First, of course, we need to promote, implement the strategy resolution through the networking. WHO collaboration centers, 20, and NGOs, official relations, and so many countries, regulatory, the networking, so many networking member states. Also, we are now going to organize experts to identify the models for good practice of integration. So how to support the member states? WHO will work on firstly some definition side, and also identify the good models and to recommend to the member states. Of course, it's on the request we also support the member states. Of course, the priority activities also I need to emphasize also there is a joint project inclusion of traditional medicine into ICD-11 the services. So here, Nana here. So the WHO classification team working on ICD-11, and also our traditional medicine team were working jointly on this. Now so far make good progress from the theoretical in the last several years, working on that part. Component now is moving to the field trial. And hopefully together they will be launched with the whole ICD-11 traditional medicine as a chapter here. So this is an important, will be an important tool in terms of integration traditional medicine into the health service system. Secondly, we also organize experts to initiate a pilot project on how to ensure the quality and also safety of traditional medicine services. Probably acupuncture will be the first intervention for the pilot project in select institutions and countries. We are also going to develop several benchmarks for practice. Will be not only in acupuncture, but we are also other interventions, and of course many guidelines, technical documents in the process. We are also working on capacity building for government officials, for the health workers, and others. So currently, is a series of workshops, training workshops, for government officials. One workshop for 15 countries, government officials who are responsible for traditional medicine in that country. So, for example, the knowledge base, the policy management development, the regulations and the integration models and the others, the exchange the experiences, and also based on the request from countries have to upgrade the healers or the local health practitioners to traditional medicine. So also one important area for training capacity building. Here it's only an example. We published also benchmark, but that benchmark is for training. You can see in different modalities. Nuo Thai is Thailand traditional medicine. There is Chinese medicine, Tina, acupuncture, Ayurveda, Unani, naturopathy. So this osteopathy. You can so different intervention modalities. That's for benchmarks for training. What we are working now is benchmarks for practice. So it's from W side. So before ending my presentation, so I also would like to hear use the DG Michael Chen is saying in the speech in the Congress of Medicine. The two systems, traditional and Western medicine, need not clash. Within the context of primary healthcare, they can blend together in the beneficial harmony, using the best features of each system and compensating for certain weakness in each. So this encourages a lot of countries, particularly for the policymakers. So after all, so WHO working on this, policymakers working on traditional medicine. So the final goal is to ensure the consumers, the patients will be benefiting from the integration appropriately of traditional complements into the health system. So the patients could make a choice when they have diseases or health problems, either to visit conventional medicine or to traditional complementary medicine providers. Thank you.
Thank you, Dr. Zhang. I'm Sanjay Banerjee from the University of York, and I work with colleagues at the WHO through the WHO Collaborating Center for Global Health Histories. Again, a slight modification of our usual format because Professor Zhang has to go off on duty travel. Are there any comments or questions? Madam, could you speak into... No, please speak into the microphone and identify yourself, please.
It's just a concern when I'm looking at, so the last quote was about saying that the two medicines have to work together, if I understood it well.
Different concept definitions come together. So you go on. What's your understanding? Yeah.
Okay. My only concern is about the lack of let's say, taking into account the social potential of traditional medicines in terms of quality of healthcare and in terms of, I don't know, even the traditional doctor has some potential for the community and for the patient itself. And it doesn't really, I mean, if you look at WHO position for the moment. I don't have the impression that this particular potential is really highlighted, if I can say so. That was my concern.
So, yes, if you have this kind of things, so we encourage you to push WHO or relevant teams to how to support or guide this area of work. So, so you are seems how to say? So the major concern is not how to say confident or about, but so maybe different perspective from me to you, because well, our team is working on this, and you can see another team, WHO team, not traditional medicine team, is working, as I said, inclusion of traditional medicine into the ICD. ICD, you know that is a very important clinical tool, right? Yeah, this is only one example. And also the department is working, as I said, the piloting project as quality improvement of traditional medicine, complementary medicine services. It will be, of course, cooperate with other teams working on the patient safety, quality of the healthcare the services. Not for traditional medicine. Okay. We also, of course, are working with other team, working on the people-centered, integrated services. WHO now is developing that strategy. Yeah, that strategy including also how to appropriately integrate the traditional medicine as part of the integrated people-centered that's WHO strategy. As you were saying, as I just mentioned, vertically or the integration. Of course, by the project for the by the scenes, for us, we have so many collaborations, technical the documents like GMP, your GACP, or quality safety or herbal medicines. That guidelines already very well cooperated, published. So many. Firstly, later, if you have time, I can share all the information with you. Secondly, you are encouraged to support the traditional medicine, the projects or activities. In terms of the how to say integration of traditional medicine, different people or different institutions may have different the definition. What we are talking about is the traditional medicine, complementary medicine, as a part to be integrated into the whole health system, which include the policy side. If the country develops national policy, including covering also the area of traditional medicine, and also the regulations, the practitioner contacts, including appropriate regulations on traditional medicine part, and for example, the education system, perhaps, and all the services, the policy side, or the relevant regulations will appropriately include, recognize, regulate, and also integrate traditional medicine into the health system, while well positioned as the qualification of education, qualification of as a practitioner, where to practice traditional medicine, or some countries also. How about the insurance system, particularly the social or public insurance, cover the traditional medicine service or not? Many countries, a lot of people out of pocket for traditional medicine. Even out of pocket, many people still visit traditional medicine service. But if for some qualified service can be covered by the social or public insurance, that will also benefit the people, right? So this you are touching comprehensive.
Do you want to respond? After this, please. Yeah. Dr. Zhang, there's a question through the internet for you from Lanzhou University. When we lack the high-quality evidence of a traditional medicine intervention, should WHO guidelines and technical documents make some relevant recommendations? Another question is how to consider patient values and preferences into these traditional medicine recommendations.
We are seeing that lack of high-quality evidence in general. But when we develop WHO guidelines or technical documents, we always, if that guidelines published or the issue, so we already coordinate all the global technical inputs and make sure all the evidence, the best evidence possible, current, collected and provided and supporting that. So it's not so every part, every the lack of evidence already. So many publications, so many research projects come up. We are seeing in general, so the lack of high quality. So of course, every technical document or guideline, WHO recommendation, particularly, we always first considering the patient value of cost preference. That's why we are working so many the quality, safety, or even for patient self-care. We are emphasizing the education and the training side. So all this we are now is considering and providing, taking the actual action to try to provide the maximum evidence and also try to ensure the safety and quality. Of course, the different country, different forms, so at a different level, different context. So how to work the upgrade the quality side or even the practitioner side, because that is a question and may have different approaches to each context.
We have a question here, madam. If you could use mic.
Yeah. Thank you very much for the presentation. It was very interesting to listen. And congratulations of getting the traditional medicine into the ICD-11. I think that's great. That will give it visibility.
Madam, could you identify yourself as well?
Yes, I'm Monica Blessner from the nutrition department. And what I just find, that is out of personal experience, it is increasingly difficult to have access to herbal medicine. I'm coming, as I said, from nutrition background, and I'm using nutrition supplements. So to get the access to those is really getting more and more difficult, I find. And I wonder whether the regulations that we put in place or WHO is fostering are actually backlashing on us in the sense that we are having less access than we would like to have. I wonder that. Secondly, I also am concerned that whether there is some kind of a publication bias. There's very little out there when you look for solid trials that are testing nutrition, for me again, nutrition supplements, of course. And what I find, in fact, is that there's a whole, they're not coming up, these publications are not being published in the mainstream journals, but they're coming up in a side branch, I would call it almost. So you find a lot on so-called gray websites where it's very difficult for even a consumer who is vaguely familiar with what one should expect and how to evaluate studies. They're not very well peer-reviewed. So there's a lack of quality of information, and I wonder whether that's also linked to the lack of data that we observe in general. So that's my main points. Thank you.
Thank you for your comments. Firstly, talking about the regulation of herbal medicine, so that it's a mandate of each country, the regulatory agents, regulators. From WHO side, we provide the technical support to the regulators for their appropriate regulation for their countries. That's important. Firstly, secondly, of course, you're talking about the lack of access to herbal medicines. But my understanding is that different countries or different regions may have different situation at different contexts. So this is also the diversified situation. So it's even the categories of regulate herbal medicines as different some as the medicines, some as natural products, some countries, some as even the regulated as a food additive or something. So I don't know you would like to access which part from where or something. That's how to say different. But we now is of course we encourage. It's actually a comprehensive strategy, right? Access is one of component. And secondly, the quality and also the safety and the rational use. So all should be concerned as when we the working on each intervention, including the herbal medicine. So from doctor's side, so we try to facilitate or provide technical support to all the part, like universal health coverage. If no access, right, we cannot talk about UNC. But now the only access is not qualified or service quality, and also a problem. The patient consumers will be affected. So of course, the globally the context is comprehensive. Even the wording in current WHO different now is the documents. I noticed that even the wording some are changing, high quality, some probably now even changing to the acceptable quality or something. But of course, we are trying to provide the best evidence possible. Also, we are facing real the world, the health system. Also, we are also facing the reality. You're talking to, for example, traditional medicine. In some areas or countries, the African one country, for example, the traditional healers, we cannot talking about the education or the qualification the same level with the Indian Ayurveda, the PhD graduates or Chinese medicine graduates. So also the different the community, the practice, the services, the resources, all should be concerned. So that's it. Talking about a lot of debate about the quality access and also even the cost issues. So that's answer your question or yours? The publication guide. Publication. Yeah. Application. So what you mean? Sorry.
They're not getting published as much as other papers.
Yes. So you're talking about, yes, already the challenge even from the member states reflected that the challenge. So not so many, particularly high quality. That means for example, the famous magazine. But that's several reasons. One, of course, as I said, financial support to this area of research is one reason. Secondly, also some, of course, the high level some researchers to really showing interest, but maybe the financial constraints is one of the problems for them, and also for some kind of research, also the methodology side need to be concerned, discussed, and what's the best applied, even the research methodology side. So WHO now is under in the process developing one document which focusing on clinical studies on traditional medicine. We'll be discussing about particularly the methodology side of traditional medicine, because for like Chinese medicine, like Ayurveda, and not only the interventions of traditional medicine, but also diagnosis. Not only concept, they have their own diagnosis patterns. And the majority cases what they are working. So some methodologies the same with conventional medicines use, some maybe some kind of methodology side, either the new one or some need to be some kind of modified or something. This kind of discussion also is one area.
Dr. Zhang, there's a question from the George Institute of Global Health from Mohammed Salam. I know you have to rush off to the airport, so the WHO survey has shown that there's lack of research data supporting effectiveness of traditional medicine and complementary medicine. Is there anything the WHO is doing to support or encourage research activities?
generally, it's not only effectiveness. Generally, in this area, the research data, as we already discussed, is generally lacking, right? So WHO now is encouraging also the research, and but of course, funding is also important. We now is mobilizing not only technical resources, but particularly the financial resources. We will now is, of course, as I said, 20 WHO collaboration centers. Many universities, they are conducting research. Some cooperation with WHO focusing on the very both interested topics. And also, when some fund available, WHO will initiate, organize the global the research focusing on several highlighted topics. Of course, we are now working on this, but some difficulties, but we will work toward this direction.
Last question, if you can keep it short, because to go to the airport.
Good afternoon, and thank you for your presentation. I'm Nicole Hum. I work for the classifications team. It goes along with the last question, really. So we know that the onus is on the traditional and complementary medicine community to demonstrate value to the health system, but as we know that there's limited access to funding. So my question is, to what extent does the WHO unit work with member states in order to include traditional and complementary medicine in the clinical research priorities?
In the what?
In the national clinical research agendas and priorities for funding.
Yes. So how to say different approach. One, of course, as I said, networking. Networking regulators policies. WHO Traditional also is networking for the regulators, and also as some piloting. The projects, some recommendations or models come out, or after studies, we will recommend to all the members, the countries, right, member states, and even the, how to say, we work together with regional offices and to encourage the member states to implement the strategy, and also the WHO resolution last year. That's all the member states agreed, approved. 194, that resolution implement, develop a national work plan, and also report to WHO. So we will work on through the some piloting global that project, and then recommend to member states. We will work to, like for one example, also last year, for example, I went to a regional committee meeting. To join that member states ministers meeting, and also several regions like AFRO also develop regional strategies in line with global strategy. So this also is focusing on the situation of that region. So also the individual countries support. So countries request WHO particularly support there, how to develop national policy, how to develop education or the licensing system of the, and also one example is the training workshop. Each time 15 countries, government officials, one official is representing each country. So all the discussions so far already 5 workshops, training works, and will be more coming in the. So that kind of conference.
Thank you, Dr. Zhang. I know you have to go to the airport. If you could just thank the speaker for his time. I'm absolutely delighted now to invite Professor Madhulika Banerjee from the University of Delhi, whose work I've admired for a very long time, to make her presentation. I see that there's no PowerPoint, but I'm sure she'll enthrall you and keep you focused on her presentation. Please. You have to use the mic so that people on the internet can listen to you.
Dr. Zhang has just left, but may I address Professor Bhattacharya and the team at the Global Histories of Health and everyone here at the WHO that has shown so much enthusiasm to be here for this lunchtime seminar. And I suppose since it's being webcast to all those who are watching on the net, thank you very much for this opportunity to speak here on a subject that is very dear to me. And it is not only a research question as far as I'm concerned, but it's something that I also have invested deeply in as an individual in terms of my thought and some limited action. So for me, it's a real privilege and a source of happiness to be here speaking at the WHO on a talk that I have titled "The Globalization of Ayurveda. Can the Future Learn from the Past?" The idea of globalization, as we know it is, as we know it today, is a global economic system across the world. Undoubtedly, this is the idea that prompts us to explain and understand the globalization of Ayurveda today as a radically novel phenomenon. In this talk, however, I hope to persuade you that this interpretation of globalization forms only part of the story. I wish to suggest that the image of a pristine and insular Ayurveda that seeks to travel outside for the first time and encounter difference in its ripe old age is not quite an accurate picture. A better understanding would recall the long history of encounters of Ayurveda outside of its local context. This history, I suggest, has some lessons for the future. The kind of globalization Ayurveda has had in the last 2 decades or so is not the only possible globalization. The consequences of a medical knowledge system traveling outside of its immediate context to other spaces can be far more positive and enriching than has been the case so far. A reading of globalization of Ayurveda in terms of 2 trajectories, historical and conceptual, opens up horizons of a new kind of globalization. So I will present my argument in 3 parts. First, I will take a quick look at the encounters of Ayurveda within and outside of its land of origin in pre-modern times, which alerts us to the rich possibilities of such encounters. Secondly, I turn to some key consequences of globalization of Ayurveda in the last 30 years or so, and argue that the story is not as rosy as it is assumed to be. Finally, I spell out the possibility of a new kind of globalization of Ayurveda by way of thinking of different conceptual frames in which the system's encounters could be positioned and understood. One of the more commonsensical understandings about Ayurveda is that it is an insular and homogeneous medical system, and that it is in the age of globalization that it is going outside of its protected shell for the first time. In fact, by virtue of being in existence for the longest time in the history of world civilizations, at least amongst text-based medical knowledge systems, and this is where I appreciate the fact that the earlier speaker made the difference between systems and forms, that Ayurveda is a text-based system. Ayurveda has for long enjoyed being both local as well as global, a terminology that may be contemporary, but the reality of Ayurveda being local and global is something that we see historically. So while on the one hand it originates and is found to be practiced in the Indian subcontinent, and I must point out that it's important to see that it is practiced all over the Indian subcontinent. It does not exclusively belong to the modern nation state called India. It traveled across to West Asia and northwards to China, and these travels are well documented. From the 7th to the 13th centuries, it is well known to historians that there were intense exchanges of medical knowledges between India and the Persian empires. Ayurveda was already known all along the Silk Route, which was a trade route, but a trade route not only of commodities, but a route of ideas as well. These travels to other lands, dominated by like medical knowledges, primarily that of Galenism, produced two outcomes. The first was that its texts were translated into Arabic and Persian, and its concepts and formulations adopted and adapted for use in these contexts. I would just simply indicate that adapted is very important. It will come back, as it did repeatedly occur in the earlier presentation. Second, it was in turn influenced and was able to absorb some of these ideas and found fruition in newer formulations in its own content, and it became a part of its materia medica. So no doubt, an intellectual property regime-like parallel, that is, control over knowledge in the form of families controlling manuscripts of formulations and keeping them secret, these things did exist, but there are accounts of continuous engagement and persuasion by those who came to India to negotiate with these families. And these resulted in sharing and the spread of the knowledge widely. While this intellectual property regime-like parallel should not be ignored as part of the reality, it was also true that a large number of commentaries and like texts were freely available and were exchanged and shared as well. This was true of its exchanges with the evolving Greco-Roman system of medical learning called Unani, and that of its exchanges with Chinese medical knowledges in the creation of Swarikpa, the Tibetan medical knowledge system. The takeaway from this long period of history, nearly 700 to 800 years, maybe more, is that this exchange through translation in both directions led to enrichment in knowledge, a knowledge that belonged in large part to the public domain. Ayurveda was also not a homogeneous medical system in its home ground of the subcontinent. While the Brihatrayee, the three major texts of Charaka, Sushruta and Bhagabhatta, which are constantly referred to in any discussion on Ayurveda, these were the main guideposts, no doubt, that for a medical knowledge system crucially linked to nature for the understanding of the human constitution and to biodiversity for its formulations. This system had to be adaptive. Given the subcontinent has several geoclimatic zones, and of the main principles of wellness is Ritucharya, daily practices of the body suited to the season, not to speak of the calibrated understanding of the human body in response to the specific balance in nature at any point in time. Good quality medicine would have to be that which was continuously adapted by the physician to the patient. Clearly then, every physician relied upon both the great texts as well as the local commentaries and local situations to carry out their practice. Adaptation and substitution were not the character of errant, but mindful and learned physicians, applying their knowledge in at least the physical context in which they treated their patients. Historically then, Ayurveda cannot be understood only in the singular, but in its plurality, not in its homogeneity, but in its heterogeneity, not only of principles, but of practice. A necessary corollary to this was the fact that the medicines were invariably locally produced in small quantities and as much as was required for a localized clientele. We'll see how this works out, and this dimension contrasts substantially with modern ideas of production, both of knowledge and of medical formulations, in which homogeneity and mass production are the hallmark. Homogeneity or uniformity of knowledge, whether in learning, practice, or of formulations, has evolved as the crucial principle of quality in modern production. Mass production, which provides easy access of commodities to consumers over large-scale markets, is counted as the only indicator of success. What is crucial to flag here is that these ideas of quality and quantity have evolved through a specific context of capital-oriented production and cannot be, I argue, established as the norms of all production per se. This is particularly relevant today as we struggle with the negative fallouts of mass production, especially in terms of the intensive use of natural resources for so-called optimal production, and the fact that the one-size-fits-all principle does not necessarily respond to everybody's needs. Equally, it is important to flag two older ideas that the older globalization of Ayurveda showed. That is, the viability of ideas traveling and being adapted, and that of a large number of local units undertaking more sustainable production systems. We will return to this at a later point in the lecture. So now let me move to the second part of my lecture. We've talked about the historical achievements of globalization and briefly touched upon how they can have implications for the contemporary. Now we go to the next part of my lecture, which is from the long-term history to looking now at the recent history of how globalization has impacted Ayurveda in the last 30 years or so. Since the 1990s, with the collapse of the Soviet Union and the drawing in of most countries of the world into the orbit of one set of global economic institutions, we have believed ourselves to be a part of the process of globalization. While its many dimensions and definitions continue to be debated, I will focus here on the three things it has specifically meant for Ayurveda. First, it has meant a large number of Ayurveda-derived FMCG products. I'm sure we all know what those are, fast-moving consumer goods products. That's how they're called in the market. As also healing and treatment regimens of Ayurveda have found a place in markets outside of the subcontinent. As a consequence, a large number of people have become more familiar with them and are eager to explore their possibilities as alternative or complementary to those of mainstream or conventional medicine. Second, Ayurveda has become part of debates and controversies with respect to some of its formulations, especially those using heavy metals. Third, Ayurveda has come up for regulations for parameters of standardization developed for biomedicine and its pharmaceutical industry. Let me turn to these one by one to understand the impact of globalization on Ayurveda. So these are three things, and we'll talk about them one by one. As is well known by now and talked about a lot, there's been a veritable explosion of products derived from traditional medical knowledge systems, not only Ayurveda, but all kinds of systems, and all over the world. While in terms of the world market, the share of Ayurveda is not very large. We must make a note of that, especially compared to Chinese medicine, for instance. In terms of its own market and its own market share, prior to the 1990s, it has been a huge leap for Ayurveda. These products, that's Ayurveda-derived products as I call them, include not only medicines for the occasional illness, but also products for everyday wellness. A variety of FMCG products like cosmetics, tonics, nutraceuticals, etc., nutritional supplements, that's one of the questions that came up in the earlier, in response to the earlier talk. All of these products have been derived. Even though they are not all medicines, they have self-consciously carried the name of Ayurveda, positioning the product in a different circle of legitimacy. While this process had already begun in India in the 1980s, real fruition came after the 1990s, when the world market beckoned. I have argued earlier that while this line of product development gave greater recognition to Ayurveda in the market, it was also responsible for taking away the sheen of being a medical knowledge system in its own right. This was visible at best in the development of wellness centers in large corporate hospitals, and at its worst in the spas and massage parlors dotting beaches and hotels, promoting what we have come to call Ayurveda tourism. Globalization-induced expansion thus has led to diversion, if not distraction, from Ayurveda's potential as a holistic healing system. This aspect links with the second visible consequence of globalization, that is of the controversy surrounding the heavy metal content of Ayurvedic medicines exported to overseas markets and poisoning unsuspecting patients who had taken them out of trust. Nothing could be worse for the reputation of any medical system. I have written on this too in some detail, so here I will simply present the crux of the argument I have made elsewhere. The Ayurvedic medicines in question in most of these cases of poisoning have been bhasmas, the ash form of heavy metals, arrived at after a series of complex steps that seek to bring out the medicinal quality of the metals and reduce and eliminate, not reduce, but eliminate the poisonous element of them. It is recognized in the system. In Ayurveda, it is recognized that the bhasmas are one of the most potent and therefore very difficult medicines to prescribe and requiring great judgment to administer and carefully calibrate along with food and drink intake throughout the period that this is being taken by the patient. This is very important to understand about bhasmas and these heavy metal based medicines. The responsibility of the physician is probably the most in the handling of this particular category of medicines. Amongst Ayurvedic physicians, they consider that they would have to think long and hard and work very, very carefully when they administer these medicines. However, because Ayurveda and indeed other traditional medical knowledge systems have acquired the reputation that their medicines have no side effects, I'm sure this is a common belief that a lot of people have now, and have also become increasingly separated from their distinctive regimen of treatment. Many of their medicines are being sold over the counter. I'm willing to, engage in more discussion. I'm having to be very brief here in my presentation. If there are questions, we can talk about this in detail. Many of these medicines are being sold over the counter. As a result, patients that have taken bhasmas unsupervised and have suffered poisoning by them has led to bhasmas coming to typify the unreliable, unsafe Ayurvedic medicine. No doubt there could have been manufacturing defects, they should have been better regulated, and they should never have been sold as OTC drugs. All of these have caused immense suffering to many patients. This has caused a lot of suffering to patients, there's no question about it. I would argue, however, that the long-term suffering is really of the medical knowledge system from which these bhasmas have emerged. What has happened is that it has exposed Ayurveda to very unfavorable kind of interrogation and suspicion. Nothing could be worse for the medical knowledge system. Finally, this is the third point about globalization and how globalization has impacted Ayurveda. The entry of Ayurvedic medicines into the competitive world of the pharmaceutical industry has meant a clamor for its legitimation by recognized criteria of certification. The earlier presentation also had references to this, and rightly so. And this is in evidence in debates in the UK, in the EU, and in the US, wherever Ayurveda has had a potential market. There can be no doubt that anything that is manufactured anywhere and sold in any market ought to follow standards of safety and efficacy, no question. The only questions are, whose standards and how are these to be established? The fundamental difference in epistemology between Ayurveda and biomedicine has made it difficult to assess either of the criteria for Ayurvedic medicines in terms of the claims of the system itself. I argue that this is perhaps one of the most important issues about globalized Ayurveda today. Each and every part of this system, diagnosis, prognosis, line and regimen of treatment is different. And so the outcomes expected are differently envisaged, even though the final one is that of amelioration from the disease condition. I was very encouraged to hear our earlier speaker referring to this very mindfully. And that's a very interesting development in the WHO position. Great patience is required for parameters of standardization that reflect these fundamentals and for them to be created. But the pace and volume of globalization, and even more the expectation of being able to sell Ayurvedic medicines everywhere in the world, is not able to accommodate this requirement. In this respect, globalization of Ayurveda has made the knowledge system, I argue, subservient to the logic of the market as it exists, and not opened up creative spaces of quality control. So the combined effect of diversion, interrogation, and subservience, which are the three effects that we've identified with the impact of globalization on Ayurveda, has meant that this journey of Ayurveda has turned out to be very different from its older journeys. This latest journey has created a new entity out of Ayurveda. One way out is to position Ayurvedic medicines in the category of herbal medicines, like those available in the European tradition, for instance. This was done by the Traditional Medicine Herbal Products Directive of the EU. I'm sure everyone here is aware of that. That came into effect in 2011. An otherwise helpful move, however, actually affects two disservices. One, it is unable to legislate for the complex polyherbals or compound drugs that most Ayurvedic medicines are. And two, it rules out from its purview a large number of drugs that include animal parts and minerals and metals. Basically then, the current forms of globalization of Ayurveda have actually led to it being both limited in terms of its own defining parameters and expanding its interpretive frame both at the same time. So this then brings me to the third part of my talk this afternoon. How do we envisage a different trajectory for Ayurveda on the global stage? If globalization has meant expansion of economic opportunities, but conceptual shrinkage, is it possible to reverse this trend? It is, of course, not easy, but I do believe that it is possible to think of a new kind of globalization if we are willing to make three conceptual moves. Everything comes in threes, I'm afraid, in my talk. I hope it's not difficult to follow. First, we need a fresh perspective on the framework of integration of Ayurveda with the mainstream system of medicine. Integration is a word that repeatedly occurs in all documents, policy documents, including WHO documents, and was referred to in the earlier presentation entirely appropriately. Second, we need to explore the idea of adaptation somewhat further. And finally, we must focus on the epistemic frame that guides Ayurveda and explore the possibilities of multiple Ayurvedas. Okay, so here we go again. I'm going to try and spell each of these three things out, and I promise that will be the end. In all policy documents on traditional medicine, whether of international institutions like the WHO or even of my own national government, recognition of the value of medical systems, of all kinds of medical systems and not only the biomedical one, has invariably invited a call for integration. The one question I have and continue to ask is, integration, yes, but on whose terms? If we recognize knowledge systems for their value as a whole and not simply as bags of recipes, from which some useful recipes can be taken out for specific medical conditions, if we are willing to do that, I believe that we would be able to deploy these medical knowledge systems much better, be it in terms much better for public health care, especially in countries like mine. For this, the effort would, of course, have to be in terms of separating wheat from chaff, in what is seen to be knowledge in these systems, how to grant recognition to them, without getting bogged down only by the parameters set by biomedicine. The effort, of course, would have to be from both ends, no doubt, from that of the researchers and practitioners of Ayurveda, and to those of policy makers and practitioners who are influenced heavily. We need to recognize that most policymakers are influenced heavily by the biomedical frame. But so long as we force the template of one system onto another, we would be unable to use the other's full potential. This, of course, is not new. It's not a new argument at all. It has been reiterated, it has been identified and reiterated time and again in many documents, in much work of international agencies, including that of the WHO. But it remains to be fully applied. What is wonderful is that disparate efforts in this general direction are in evidence on the ground. They need to be identified and incorporated into policy much more carefully. Examples of these are to be found in the work of community health groups in India. Often when we make policy, we look at institutions, administrative, political institutions that have already been engaged in them. But the work of organizations and groups outside of them sometimes are taken into cognizance, not always enough, I think. And we have groups in India that are engaged in the processes of recognition and legitimation granted to providers of healthcare at the village level. I was very encouraged when they were made reference to by Dr. Zhang that they are the primary providers of healthcare for a majority of populations in most parts of the world. Indeed, that is true even of India, even though we have a huge public health system. But a majority of the population is. That's a reality. They are outside of its pale. And so a process to grant recognition and legitimation to the healers that do the job is very necessary. These groups have made assiduous efforts to identify the terms of recognition that respect the value and character of the work of folk healers, while being steadfast about the commitment to rational use as we know it. Thus, they are able to demonstrate remarkable possibilities in lines of integration. It is not as if examples like these do not abound all over the developing world. Especially, they are available, and what we need to do is empower them urgently with some kind of institutional form so that they are recognized as players in the politics of knowledge, because that's what it is. It's the politics of different medical knowledge systems being played out. Adaptation is another conceptual category we've not explored to its full potential. While there cannot be any doubt that safety, efficacy, and quality of medicines, traditional or otherwise, need to be paramount, it should be possible to review the principle of standardization that underlies them. Standardization has evolved with specific parameters that could govern homogeneous commodities produced in large quantities, as I said earlier, that is on a commercial scale, sold across disparate markets far and wide. Applied to medicines, it would further mean the supposition. When we say homogenization, homogeneous medicines, it would mean the supposition of the uniformity of human bodies across geoclimatic zones, seasons, and physical environment, stricken with diseases with common cause and therefore common cure. So standardization presumes all of these things as well. Now, the operation of most traditional medical knowledge systems has shown time and again that this supposition, while it has great value and has done great good to the condition of humankind in respect of many disease conditions, does have its limitations. Like all good things, it does have its limitations. And so it should be possible to explore the core commitment to quality, safety, and efficacy that current standardization processes seek to establish and bring them to bear on adaptation as well. Dr. Zhang also talked about adaptation, and I was very interested to hear that he was talking about suitable integration, suitable adaptation, and that shows that some kind of development in the thought process on this has begun, and that's very, very welcome. Let me explain what I have to say with an example. Pioneering research work has been carried out on the treatment of rheumatoid arthritis by randomized clinical trials in which both Ayurveda and biomedical experts collaborated. I'm sure everyone here must be familiar with this work, as it has been published in leading academic journals, the kind of journals that have, higher citation indices and so on, the mainstream journals. And this work was done under the aegis of the National Institute of Health in the US. Let me state the most important thing to my mind that comes out of this trial, that randomized clinical trial. I think what emerges from that trial is that it is the trial of communication between epistemologies with the determined intent to converse while continuing to stick to their own languages. This is an extremely difficult thing to do, but I think that this is a trial that has begun this possible conversation. And it is possible because at least one end made the effort to continuously speak in two languages, speaking in Sanskrit as well as English, of Ayurveda and biomedicine, the languages of the two medical knowledge systems, and that enabled dialogue. This is the effort of adaptation without the connotation of compromise it has carried so far, as opposed to standardization. I believe it is really worth pursuing. That, in multilingual societies, the diversity of tongues is not a problem, as many in monolingual societies presume. People usually speak one language quite fluently, and they follow the idiom and the syntax of one or more other languages than their own. They do that because they've grown up hearing both many languages and they speak at least one language quite well. So when conversations happen, each speaks in their own tongue. In multilingual societies, this happens quite a lot. I may speak in Bangla and someone else may speak in Hindi. And we both follow each other's languages very easily. We respect the structure of each other's languages. And we listen and we converse. I think that this mode needs to come into research on traditional medical knowledge systems. Definitely the research in Ayurveda has shown. And if we truly believe that the world is a global village, then this has to be a way of the future. I know that India's villages certainly, and many others, I'm sure, many other parts of the world, follow this multilingualism quite successfully. The problems of multilingualism are often highlighted, and I think this particular value is missed, and therefore I would wish to really flag it quite clearly in this presentation. And the third and final conceptual trajectory that I have to offer this afternoon is for a radical rethinking from first principles. Let us think in essence, what is the Ayurvedic method of medical knowledge? It is about understanding the body constitution in terms of the constitution of nature around it. It seeks to understand the plants and the animal kingdom and believes, this is very interesting, there is no plant that does not have medicinal qualities. Many of you may have heard that story of how when in an older learning system, one young man was told by his guru that he has qualified. This is a story often told in India. He's qualified for practice and he can go ahead, and practice, but his guru said there's one question you have to answer and then you're free to go. What was that question? Go find me one plant that does not have any medicinal quality. The young man traveled far and wide and looked at all the plants he could identify, and after several days of search thought, that's it. After all this time and effort, I'm going to fail this exam. Very disheartened, he came back to his guru and he said, I couldn't find any plant that didn't have a medicinal quality. So tell me where I have failed. And the guru said to him, but you haven't failed. You've passed the real test. You know that every plant has a medicinal quality. This is one of the most valuable things that Ayurveda has to provide. So it's about body constitution, constitution of nature, and the intrinsic value of all plants with some kind of medicinal quality. It seeks to understand the balance between the body, the human body, and the larger atmosphere. Very grandly, sometimes they call it the cosmos, And what it does, okay, it seeks to explain both illness and wellness in these terms. So in fact, we have an interesting generalizable principle of each body needing to have a balance within it and embody a harmonious natural context in which it lives. So what conceptual trajectory can be derived from this? To answer this question, I draw upon insights from the social sciences. Some of you may know that in recent times we've had a rich debate on alternative modernities. This debate has sensitized us to the fact that modernity has had a contingent connection with Europe, and that we have had multiple historical trajectories of different kinds of modernities across the globe. I wish to suggest in similar vein that Ayurveda is not only specific to the natural context of the Indian subcontinent, and that it is not only that the collection of medicines that can be made from the plants native there, and therefore it need not be exported or imported. It is not unique to the Indian subcontinent. I argue that Ayurveda's connection to the subcontinent is contingent, and that it is potentially universal, because every country, every society, in applying those basic principles, should be able to develop its own Ayurveda. So let 100 Ayurvedas bloom. This, I believe, is the real meaning of a truly globalized Ayurveda. Thank you.
Thank you, Professor Banerjee, for a wonderful talk. Questions, comments? Please. And if you could use the mic and identify yourself as well, please.
Thank you. My name is Nenad Kostanček from the classification unit in WHO. And as Zhang already mentioned, we are in the process at the moment of revising the ICD and incorporating a chapter on traditional medicine, which at this stage is focusing on traditional medicine of Asian Chinese origin as module 1, but there may be other modules in the future. And first of all, thank you very much for this very enlightening and interesting talk. And I would like to pick up on some of your points which I very much sympathize with, both in terms of the concerns, the kind of plea you're making and the vision you're having, in particular around this notion of stick to your own language and around the notion of, integration in what terms and what standards are we talking about and who is making the standards. So if you look at ICD, which has been or is the standard for Western medicine for many decades or centuries, depending on how far you look back in history, and now trying to do a similar thing for traditional medicine and to allow communication and expression in their own languages, of course you come always to this point where you think, where you realize it would be very helpful if we can show how this language is used in its own context. And this is where my question comes. When we look at Ayurveda within the Indian subcontinent and what we call, in our jargon, the use cases of your medical knowledge system, let's forget about the moment the intervention part, but just the diagnostic part, because at the moment we are working on ICD. We will maybe in the future have an intervention classification as well. But just looking at the diagnostic Ayurveda system, what do you see as the kind of key use cases, particularly with regard to 3 areas? One is the reporting of the condition. Even in Zhang Xi's presentation before, we were hearing about these are the top 5 conditions for which traditional medicine is used. But if you look at these conditions, these are Western medicine conditions. We are not talking about, let's say, liver Qi deficiency or any genuine form of traditional medicine conditions. So I would be interested to understand if there's any kind of health reporting or epidemiology at population level which is using the Ayurveda diagnostic conditions. That's number one. Number two, is there any use case from a reimbursement perspective where you see that insurance companies in India or Sri Lanka or in the subcontinent are actually reimbursing services based on a Ayurveda diagnosis? And the third question, what about, you mentioned clinical trials, clinical decision making. Are practitioners themselves communicating their findings in terms of research, their practice in terms of diagnosing the patients within their own language system, and to which extent is this documented or formalized?
Okay. Do we take one question at a time, or? Okay. The principal problem in terms of reporting, whether in your first question of diagnostics or about decision making, the second one is slightly different, but the whole problem is that the context is articulated always in Western medicine terms. We must remember that the context of practice of Ayurveda has not been in what we understand today to be a public health discourse. So therefore the requirements of what a medical knowledge system is supposed to provide have to evolve from Ayurveda as well. It has potential, it has directions, it has contribution to make, but it has to be teased out of the system. But then if we try to tease it out, and this is what we've done so far, if we try to tease it out according to categories that are completely alien to it, we are not going to be doing it very successfully. It has not happened so far to the best of my knowledge. Whenever it does happen, it's very marginal and does not come into the mainstream discourse, and definitely those who make policy are not brave enough, I think, and I would make a somewhat, rash statement there. But I think that there's not that effort on their part to look at whether different kinds of Ayurvedic categories can come out, which can be used in, let's say, things like ICDs. So this reporting is not actually happening because we are not even making the space for it. It's very strange because all the time Ayurveda is expected to live up to the expectations that biomedicine sets out. Okay, these are the questions. Can you answer them? Now, this is not dialogue. So I think if there isn't, and I think there isn't very much on this, it is because of this kind of interrogation, which doesn't yield it very much. In terms of clinical decision making, there are fora of dissemination, of discussion amongst Ayurvedic practitioners now that there's been an institutionalization of the learning and practice for such a very long time in India. But it's still quite, it's not as widely shared as it ought to be. And the fact that actually Ayurvedic practitioners are coming up and responding to so many new disease conditions, new kinds of requirements, new kinds of challenges, that those ought to be shared amongst a large community of Ayurvedic practitioners. The forum for that is not being systematically created. The only forum that most Ayurvedic practitioners want to create and want to be a part of is one in which they legitimate their work according to biomedical criteria, because that's what gets them citations, that's what gets them recognition, and eventually that's what gets them funding for their research. So let's be very clear that that's the hierarchy of knowledge that structures the way in which information and analysis out of a knowledge system emerges. So that is still dominates. And it's very interesting for a social scientist like myself, and there are many social scientists who now work on Ayurveda in India. When we talk to one set of people in one place, then go and talk to someone else in another place, because that's what our social science requires, that we speak to different kinds of constituent elements in that community. They say, where have you heard this from? And you say, no, but then so-and-so in Maharashtra was telling me this, and do you do this in Banaras? And it's maybe not between Banaras and Maharashtra because they're very well known, but if you go to a smaller place, they have no idea that this is what is going on in another part of their own community. And they must remember that this is a huge country with very varied practices. So there are those kinds of problems, and that communication doesn't really happen. As far as insurance is concerned, it's in a very nascent state in India as far as medical insurance is concerned. In terms of the debate about whether insurance will reimburse Ayurvedic treatment, it's very, very much at the nascent stages. This is not being really, it's coming up for discussion, but nowhere will insurance companies actually get into covering this yet. There's a proposal by the government to bring up health insurance, but even in that proposal, the government's own proposal, where the government supposedly does have some space, and Ayush and all these entities have been created by the government, but in their insurance schemes, Ayush does not figure so prominently at all. So that tells you something about the power structure as far as insurance is concerned, not to speak of the fact that 85% of people in India do not have any organized access to medical care. So for them, insurance is a complete unknown quantity. That must be flagged as well. Thank you.
Any more comments, questions? Madam, please identify yourself.
I just can't help giving you my
Can you identify yourself?
I am Dr. Pramila Kapoor. I am a botanist with the starting degree, an ecologist, and I worked in ethnobotany and traditional knowledge, especially in the area of all these traditional knowledge systems. I just got up to say that thank you so much to you and to Dr. Zhang, because I have been one of the person behind the scene wanting that this system of knowledge becomes integrated and the human race, which is going forward in all pursuits of bringing well-being, has to take the elements of this wonderful knowledge. And I just feel it's my duty to say thank you. I wish the knowledge system of Ayurveda or the other system which have been in India were given some data which you alluded to. Of course, you can't cover. So would it be possible that you make it available to those who are part of this workshop or this seminar or later on, so that we can take benefit from that? Thank you very much.
Well, thank you. I mean, I'm glad you felt that this served some purpose. But as far as data, I don't know what kind of data you're talking about, but there is actually a lot of data available about Ayurvedic practice and indeed all the other systems. And there's data available on trials and on medicines and the industry and education, all kinds of different aspects. I'm not sure which kind you exactly are alluding to.
First will be your own presentation and all the trees you are referring. Of course, you have synthesized it intellectually, but as a person who would like it to be integrated or used in policy, we would need to substantiate, say, CDRI, CMAP, Ayush, say from the Indian context or the regional context. We will have to say that these publications, as you mentioned, that most of it is available but not synthesized, and it is only in reference to biological sciences. But as you being the social scientist, we would need you to help us have the access maybe to the key literature you alluded to. Thank you.
Okay. That should be easily done. It would be a pleasure to share anything that one has here. Absolutely.
We have a question online. I'm aware that this room is only booked till 2. We have time? Okay, good. So This is from Dr. Sabina Hussain, gynecologist and public health specialist from London. Says, good and topical issue, globalization and internet technology offers us huge opportunity to redefine the politics of health and healing. Couple of comments reflecting my view. Do you think social scientists have been able to effectively communicate with the Ayurveda practitioners community as well as those who make policies on Ayurveda? If yes, what are some of the important contributions? If not, what are some of the challenges and how to strengthen the contribution? I think we should focus on that.
Yeah. Thank you for that really comprehensive question, very valuable question, and I'm glad I have the opportunity to talk about this. To answer the first direct question, do you think social scientists have been able to effectively communicate with policy and practitioners? If we look at the social science literature on Ayurveda and indeed other traditional medical systems over the last 30 years or so, 30, 40 years or so, I think there's been a concerted attempt to enable this communication, and a fair amount of analysis and interpretation has come out of that. So there's a there's a fair amount of academic literature now coming out, and the heartening thing is that there are more and more. When I started work in the late 80s, since then a lot more people are now interested, and younger scholars are interested in these questions. So the possibility that these questions will be taken forward is much higher than it was ever before. But in terms of having an impact on policy, that's a very interesting question, because when I started, and I started doing my field work, talking to practitioners, but of course you can't do any work on any medical knowledge system unless you speak to the practitioners. They would really askance at me and say, really? Political scientist? What kind of interest could you possibly have in Ayurveda? Politics of knowledge, what does that mean? Of course, that's a question I'm still answering very often. But what it does mean is that, we are talking about one kind of divide in the medical knowledges, which is between biomedicine and Ayurveda. There is another huge divide between the social sciences and the natural sciences. And in the hierarchies across the world, and certainly in India, the social sciences are very much at the bottom of the heap as far as the knowledge hierarchies are concerned. And for them to come out of that and talk to the natural scientists some more, accurately it would be to make the natural scientists talk to them, such that we could have some say in policy making, is an uphill task. There's no question about it. I dare say, though, that in Ayurveda, I have found the most wonderful listening ears, and responsive as well. And I've been very privileged to have had long conversations with many practitioners, extremely learned and people of depth, who have done these kinds of translations that I alluded to in my talk, who have also some kind of impact on policy. But then it's a fairly roundabout route to get to policy. And I must also say that there are many social scientists who feel that their work is that of analysis and interpretation, and not to actually make policy. There are those hierarchies within the social sciences as well, so it's a complicated world. But people like myself who believe that analysis, interpretation on the one hand needs to travel the trajectory towards policy, do find it very difficult to actually reach the ears of policymakers. And sometimes they listen, most often they don't, and they don't even ask to listen, actually. That's to put it very bluntly. So so while I would really like to say that yes, there have been important contributions, they haven't. That's God's own truth. This is the challenge of languages of interpretation, challenge of languages of application, and we need to go beyond that. And also, I think that as a social scientist, I may have focused on Ayurveda because that's the only way you can do some kind of rigorous analysis. You focus on one and try to understand one system for itself. But then I find often that there are reverberations across the systems So for me, actually, you know, what the Dr. Hussain is asking about removing barriers and understanding the whole elephant is very, very important between traditional medical knowledge systems and between biomedicine and Ayurveda. But what I find is that the way in which knowledge is structured, it is in the interest of all practitioners of knowledge to guard their disciplines with their life. And, you know, interdisciplinarity is a virtue that is often talked about and rarely practiced. So there are so many interdisciplinarities involved when social sciences have to traverse the entire distance of understanding medical knowledges and then getting to policy. That's something that's not going to happen in a hurry. But people like myself are not likely to give up easily either. So perhaps there's some hope. There's certainly some hope. Just one small thing I'd like to add. I often find that when we are talking between different practitioners and to policymakers, because we are insider-outsiders, because once you're involved in the knowledge system, you understand it well, at the same time you know how to translate it for those who are outside of it. We speak for knowledge systems sometimes in a more useful way for them. And often I've found practitioners telling me, really, you're a much better spokesperson for us than we can ever be for ourselves. And that's a very important role I see for myself, though not uncritically. That's very important to say as well. Thank you.
I think we need to end here, and I'd like to thank both our speakers, the audience, all of you for being here, WHO colleagues who supported the GHH seminar and the first seminar for the year, Miriam, Zhang, wonderful colleagues to have. The funders, the Wellcome Trust, my own colleagues from York who've come over to support this event. We're going to have several more GHH seminars over the course of the year, and I look forward to seeing more of you over the, right through 2015. If you're too busy, you're somewhere else, log on and interact with us through the internet. So thanking all of you, but especially the speakers, for a wonderful seminar today. Thank you.
Thank you.